Hello and welcome to this talk on atrial fibrillation. AF is one of the most commonest cardiac arrhythmias, and it's something which, regardless of what specialty you find yourself in, you will encounter patients with AF, and you may have to uh, initiate some management or refer to the right person. So I'm going to hopefully by the end of this talk we'll be able to improve your understanding of atrial fibrillation and become more confident in diagnosis, investigation, and management of this common condition. So, to achieve that, through this talk, I'm going to go through definitions, the natural history of atrial fibrillation, clinical features, diagnosis, and investigation, and really focus on a bit about the management as well, which will involve stroke prevention, uh, rate versus rhythm strategy, and also looking at any precipitating or concomitant diseases. So, as I said, atrial fibrillation is the commonest sustained cardiac arrhythmia. It has a prevalence of around 2%, which in the UK works out to be around 1 million people with atrial fibrillation. And it's not benign. It is associated with an increased morbidity and mortality risk, predominantly due to the effects of stroke and thromboembolism. In fact, it's one of the leading causes of disability in the UK, and it costs the NHS around £500 million per year, which is around 1% of the NHS total budget. So, yeah, it has got significant consequences. So, what does it mean by atrial fibrillation? Well, the fibrillation refers to the quavering or the shivering of the muscle fibers within the heart, and atrial fibrillation is referring to this process happening within the atrium, particularly the left atrium. In terms of the diagnosis, it's characterized by the ECG, where you will note that there is an irregular rhythm, and you'll find that if you try to look for any P waves, either they will be absent or they'll be quite abnormal looking. You just have to be careful because sometimes you can see some P waves and some sort of atrial activity, and this is the fibrillating. These are the fibrillating atrium, and it's not sinus rhythm. So just be careful if you do see that. Don't think that it is sinus rhythm. And just a reminder of what sinus rhythm looks like. Clearly, the P waves are completely different here, as you can see. These P waves are sinus P waves, and you look at the atrial activity within atrial fibrillation. Really, they're not normal P waves. So this slide really was brought about in the 2010 ESC guidelines for atrial fibrillation, and actually it's a very important slide because it goes through the natural progression of atrial fibrillation. And if you understand this slide, then you really do understand atrial fibrillation quite well. So at the bottom here, we have the time going from the left to right. And as you can see, atrial fibrillation tends to progress from periods of atrial fibrillation, which are the blue lines here, that are infrequent and short-lived, to permanent atrial fibrillation, where you're in continuously in atrial fibrillation. So in terms of most patients will have a period where they have silent atrial fibrillation. In other words, they may not have any symptoms. They're not even aware that they have it. And there comes a time where they have their first documentation of atrial fibrillation, and this is usually performed on a routine ECG, it picks up that the patient has atrial fibrillation. At this stage, it's important to assess the patients for stroke prevention and if necessary, start them on anticoagulation. As well as that, it's important to look at the rate and make sure that their rate is adequately controlled. And thirdly, it's important to look for any concomitant conditions that might be contributing to atrial fibrillation and to make sure that those are addressed. Now, what happens is that these paroxysms, now a paroxysm is basically an episode of a sudden episode of atrial fibrillation, so where the heart is in sinus rhythm and then suddenly it flips into atrial fibrillation, and then it may go back into sinus rhythm. That's called a paroxysm. These paroxysms of atrial fibrillation can, as time progresses, they become longer in duration. For example, they may have been lasting about 30 seconds or so. It may then progress to lasting a few minutes, 10 minutes, an hour, etc. And they also become more frequent as well, so they're happening more often. At which stage a patient may become symptomatic and they may require a bit of help to cardiovert them back into the sinus rhythm, and that can be done by electrical means or it can be done by the use of antiarrhythmic drugs. Also, ablation may also play a part as well, and we'll talk about that a bit later on. So, the patient has the paroxysmal atrial fibrillation, and then you do well, you get them back into normal sinus rhythm. They have a period where they are free of atrial fibrillation, but then it may return, and often if it does return, it may last a bit longer than earlier. And if it does last more than a week, so anything up to between 30 seconds and a week is considered paroxysmal atrial fibrillation, and anything more than a week is up to a year is regarded as persistent. Long-standing persistent is more than a year. So when they have this persistent atrial fibrillation, again, the patient may be compromised, they may be symptomatic, in which case you may need to do further attempts of cardioverting them with antiarrhythmic drugs and repeat ablation procedures, repeat electrical shocks, etc., etc. And as time goes on, eventually the patient will be in a position where they are continuously in atrial fibrillation, and we call this permanent atrial fibrillation. So really, you may find that when you come across your patient with atrial fibrillation, they may fall anywhere in this time scale. So you may see them in their first documentation, you may see them during their paroxysms of atrial fibrillation, you may see them during a persistent episode, or you may see them with permanent atrial fibrillation. So I've kind of talked about the definitions, and it's really important in cardiology to understand what all the different definitions mean, because otherwise you get very confused. And so just to recap what the various important definitions in atrial fibrillation are. So silent refers to them being asymptomatic. First documented AF really refers to the first time that there is an ECG diagnosis, or that's the documentation in terms of the ECG documentation. Paroxysmal is a sudden attack of atrial fibrillation lasting anywhere between 30 seconds up to a week. Persistent atrial fibrillation is more than a week. If it's more than a year, then we consider that long-standing persistent. Now, often there's a bit of confusion about what's the difference between long-standing persistent atrial fibrillation and permanent atrial fibrillation. Well, the main difference actually is that with permanent atrial fibrillation, both the physician and the patient have accepted that they will remain in atrial fibrillation, and there are no plans to try to achieve sinus rhythm. If there is, or there are still plans to try to get the patient back into a sinus rhythm, then we would call that long-standing persistent. So the difference really is quite a sort of philosophical difference. So lone AF, now lone atrial fibrillation is actually quite a rare entity, and it refers to this young group of patients who have a low risk, um, where they develop atrial fibrillation without any other cardiac disease. Now these patients, they do pose a low, they have a lower risk basically, and there's you look at them in a slightly different way. Often, one way to look at that is that, well, it's an electrical problem, and therefore they may benefit from seeing the electrophysiologist. Valvular AF. Now, valvular and non-valvular AF. Now, these terms actually are important for um, choice of anticoagulation in stroke prevention. Um, and there is a bit of dispute and difference of opinion about what constitutes valvular and non-valvular AF. So the sort of probably the most widely reported definition of valvular AF is patients who have either prosthetic valves, heart valves, or they've had a previous repair, or they've got mitral stenosis. Really, that's what's considered as valvular AF. If you have other valvular conditions like aortic stenosis, um, then or if you have no valve disease, then you refer to that as non-valvular AF. Okay, so in terms of what causes atrial fibrillation, what's the etiology? Well, really, it should be thought of as a continuum of the cardiovascular disease spectrum. It's usually a result of lots of processes that have occurred over a period of time, and it's often associated with other conditions such as hypertension, uh, coronary artery disease, structural heart disease, which could also include things like cardiomyopathies or valvular heart disease, as well as heart failure. Um, Also, there are endocrine conditions, most notably patients with thyrotoxicosis can develop atrial fibrillation, and in fact, that's one of the reversible causes. But it's also associated with other conditions like diabetes and obesity. In an acute setting, hospital settings, quite often you find that patients who have infections or metabolic derangement can often precipitate atrial fibrillation, and unfortunately, interestingly, there is some data to suggest that certain endurance sports increase the risk of developing atrial fibrillation. So, marathon runners and cyclists, it can also increase the risk of developing atrial fibrillation. So in terms of the clinical features, so most of the time patients are actually probably asymptomatic. They're not aware that they've got atrial fibrillation. But those who do have symptoms, often it's palpitations, or they feel breathless. They may have chest pain. Often it's non-specific symptoms, generally feeling unwell or just generally tired and fatigued. When you examine the patient, do check their pulse. You may find that it's irregular, but be careful because that's not always present. Particularly if they've got paroxysmal atrial fibrillation, you may have caught them at the time when they're in sinus rhythm. Secondly, be careful with the irregular pulse because other reasons why people may have an irregular pulse. For example, they may have ectopics. In addition, you should check to see whether they have any signs or symptoms of heart failure or any other precipitating conditions, such as thyrotoxicosis, if they've got an enlarged goiter, for example. And lastly, sometimes you may find that patients present with the complications of atrial fibrillation, notably stroke or thromboembolism. Okay, so how do we go about diagnosing atrial fibrillation? Well, as I said, the diagnosis is based on ECG. But interestingly, there's some evidence to suggest that simply palpating the pulse can pick up around 2% of cases of atrial fibrillation, and that came from studies looking at opportunistic screening for AF with pulse palpation in people over the age of 65 going to their GP surgeries for a flu vaccine. Um, but obviously, you need an ECG to actually confirm the diagnosis. And what they've also found is that the more prolonged the monitoring, the higher the diagnostic yield. So a 24-hour tape can pick up 10% of cases, and if you have prolonged monitoring for 7 days, you can pick up over 15%. So it's quite important, particularly in groups of patients where you have a very high index of suspicion. So, for example, those patients who've presented following an ischemic stroke or TIA or other thromboembolism. For these kind of patients, you want to be looking for AF pretty hard, and you can even go up to sort of 30-day monitoring, which is quite convenient.